So, hi everyone. Good afternoon. I'm delighted to be here to talk to you about innovative advocacy in decentralized Indonesia, learning from AFP Indonesia experience. Next slide, please, Erika. In 1999, Indonesia began a process of rapid government decentralization from a formally strong centralized government structure. Furthermore, the Law on Population and Family Development was issued in 2009, stated that family planning no longer under the direct control by central government and given the authority to district or municipality government. With 34 provinces, 514 districts or municipalities, and over 80,000 villages, local government do not place the same emphasis on family planning issues. This has led to a situation that is not beneficial to developing and implementing an effective family planning program locally and nationally. And we can see from the figure that by 2015, only 26 districts have a standalone family planning office. Others mostly merge with other offices such as women empowerment, child protection, and so on. Also, in generating demand for family planning, the number of family planning field officers decreased from 33,000 in the 90s to 20,000 in the year 27. And consequently, family planning progress has stalled over the past decades. Although the modern contraceptive rate is high at 59.5%, the method mix is highly skewed towards short-acting contraceptive methods. The unmet need is also quite high at 14.4%. However, these are the statistics for married women only. And then just recently, Indonesia passed the village law in 2014, and it gave villages leaders control over their own development agendas and budgets. Next slide, please. Responding to the situation, the advocacy effort through Advanced Family Planning Program is focused to increase funding and establish an enabling environment for family planning. And by the end of this project, we expect an increase in the use of family planning, especially for long-acting and permanent method. Not only at the national level, AFP also operates at the local level. We operate in 4 provinces and 10 districts. Its approach has been already adopted in total of 11 provinces and 157 districts. This adoption is self-funded or funded by other projects. Next slide, please. The AFP approach was developed based on the needs that family planning is a multi-sector issue from the national down to the district level. Therefore, a working group at each level was formed. At the national level, we established National Family Planning Champions Forum. And then at the provincial level, we established provincial working group and district working group at the district level. The members are representatives of family planning duty bearers and champions, such as Family Planning Office, Health Office, Planning and Development Agency, Doctors and Midwives Association, and so on. AFP provides support to the working group with capacity building, technical assistance, implementation support, and also monitoring and evaluation. Next slide, please. These working groups are the ones who play important roles in advocating decision makers. Typically, the advocacy conducted at the district level starts by forming a working group, and the working group is endorsed by the local government for its sustainability after the project. And then after that, we provide capacity building to equip them, to equip the working group members with the capacity to developing evidence-based advocacy that responded to the district needs and also priorities using AFP SMART approach. And then the working groups develop annual advocacy strategies and work plans, and then implement and also monitor it. Next slide, please. And in response to the new village law, AFP Indonesia developed a village advocacy model called 3A's advocacy, 3A's family planning village advocacy. This model ensures that village advocacy conducted aims to build network at village level by creating agents of change for family planning called family planning village team. And then to ensure family planning activities are allocated in the village budget. And the last one is to increase access to qualified family planning services by ensuring villages midwives are certified and can provide family planning services. This village advocacy model was first implemented in one of AFP districts in Karanganyar in 4 villages by the end of 2014. Next slide, please. And started in 4 villages. Family planning village team was formed in March to April 2015. The teams that seek to promote family planning, particularly long-acting and permanent method, consist of village leaders, village government boards, cadres, religious leaders, community leaders, midwives, family welfare organization, and so on. The family planning village team started implementing activities in May 2015. Next. As a result, now all districts in Karanganyar, there are 162 villages in Karanganyar, apply this village advocacy strategy. Supporting policies such as district and village head regulations, endorsement letters, and decrees were issued to strengthen the implementation of family planning program. And all 162 villages in Karanganyar now allocated from US dollar 80 US dollar to 440 US dollar per village per year, or a total of 49,937 US dollar for family planning activities at village level in 2015. And in 2016, the allocation is increased from 80 US dollar to 2,560 per village per year. And this strategy was also adopted and applied in an additional 24 villages in 6 districts through improving contraceptive method mix, a project funded by USAID and DFAT. Next slide, please. And within a year of strategy implementation, we can see a promising impact. From the total of 28 villages, we started this model for villages from AFP areas and 24 villages from ICMM areas. There is a significant increase in the number of LAPM or long-acting permanent method new users. From the figure, we can compare the number of long-acting permanent method new users between 2014, before the strategy implemented, and 2015 after the implementation. For example, we can see the male sterilization new users is only 8 in 2014 in the 28 villages, and increased to 169 in 2015. Next slide, please. from this process, we've learned that it is very important to seize the moment. AFP Indonesia is timely and responsive to the current situation. When the village law is enacted, we are very ready to act. And also, we need to pay a great attention to budget cycle schedule, because we need to coordinate efforts in tandem with the village development meeting for developing villages' annual work plans and budgets. And the last one is getting support, proof integral to commitment by village policymakers and providers. This is simply for the buy-in from the village government. And if you like for further information, you can click to the link shown in the slide to our case study. And then next slide, please. Oh yes, this is the last slide. Lastly, I would like to acknowledge and thank our partner, Gates Institute of Population and Reproductive Health at the Johns Hopkins Bloomberg School of Public Health, and also our funders, the Bill and Melinda Gates Foundation, and the David and Lucille Packard Foundation, and the William and Flora Hollett Foundation. Thank you. Back to you, Erica.
Thank you very much, Dini, and thank you for your perspective on the Family Planning Village Advocacy 3As. Very interesting. So we'll move to the next presentation, which is from Rowlands Kaotcha from the Hunger Project Malawi. Over to you, Rowlands.
Thank you very much, Yanika. So I'll be presenting on the advocacy work we did last year in the year 2015 with financial support from IPPF. If you can go to the next slide, Erica. So the main advocacy issue that we had was on the condom procurement financing, that it is largely done by donors, a situation which is not sustainable, because in the recent years we have seen dwindling support from donors. So about 99% of the condom procurement in Malawi is done by the donors, and the effect of that is when the donors choose not to procure condoms due to various reasons, we have increase in pregnancies, increased pregnancies among adolescents, increased rates of HIV infection, and many other factors that result out of that. So we developed an advocacy approach. We developed a policy brief, which we were using to engage with policymakers. And we also learned from, did a paper, learning from the best practices from the region. For example, from South Africa, where 500 million male condoms are bought using tax money. In Zimbabwe, where they have established a trust fund for HIV products procurement, and about 3% of all taxable income is used to finance HIV HIV activities. Also from Cameroon and Niger, where airline levies are used for health programs. So we packaged that document, which we used to engage with the Parliamentary Committee on Health. And we also did a consensus building, consensus building sessions with our peers, institutions that are involved in HIV related work in Malawi. So we can build a case and we can have a unified voice. Our target, the primary target group was primarily the Ministry of Health, the Reproductive Health Department in the Ministry of Health. Because that's the one which is responsible for procurement of products. And then the second, our secondary target group was the Parliamentary Committee on Health, because we aimed at lobbying them to increase their oversight role. So family products procurement budget line could be increased, and then to monitor the family planning products being procured, and also to lobby them so they could start working with the executive arm of government to set up a specific levy for family planning programs in Malawi, and also to lobby for the total marketing approach adoption in condom programming. What we expected to achieve out of that advocacy work was that the government of Malawi, through its Ministry of Health, Reproductive Health, the Reproductive Health Unit, would commit at least 10% of the total annual male and condom procurement, towards the male and female condom procurement from that particular department line, budget line. Next, Erica. And so, briefly, I would like to present on to what extent we achieved the advocacy goal that we had set. The processes we did with the Ministry of Health, the Reproductive Health Department, actually resulted into a positive outcome because they actually committed to be allocating 10% of their procurement family planning commodities line towards male and female condom purchase. The good thing is that the condoms are already appearing on the Ministry of Health Essential Medicines list. And so when that is done, it means that this year we should result into a 5% increase of the total number of condoms procured annually. That is holding all other factors constant before this particular year, 2016. Then on the parliamentary committee, they made a commitment actually, looking at the best examples from the regions and all that. They committed not only to be monitoring the implementation of the family planning budget and ensuring that condoms are being procured, but to also start engaging with the executive arm of government so that a trust fund could be set to be used for HIV and AIDS. The advocacy work also resulted into increased awareness among the civil society organizations on the state of condom procurement in Malawi. It was really surprising to see that other civil society members were not aware that there is actually a huge risk attached to to condom procurement in Malawi. In light of the fact that it's 99% donor-based, and with the dwindling donor support, the procurement of this particular important product is actually being affected. Next, Erica. Now, let me mention that this work has had its own barriers along the way. Most significant one is, I'm sure some of us on this presentation, on this meeting today have read about the impact of the El Nino on this side of Africa, and Malawi is one of the hit countries. So the recent reports that about 5 million people in our country are faced with food insecurity is sort of like diverting the attention of the government on priorities requiring domestic financing. And so that's a threat that we've faced, which we've managed to mitigate by continuously engaging with the authorities and making sure that the commitment that was made before this particular announcement of the El Nino impact was done should actually be sustained, and I'm glad to see that it has been maintained. And the session of Parliament is currently meeting, and so we look forward to this particular budget line being part. It's actually part of the presentation, the submission that has been made by the department. But there's also the issue of bureaucracies, like in most governments in Africa, on the procurement of products, which affect the timely delivery of the product. So on this one, the issue was, okay, if we eventually shift from the donor-based, donor-dominated procurement system, which is a good thing to happen, but at the same time we should also be mindful that there are inefficiencies in the procurement system of the government due to bureaucracies, which might actually result in product stockouts and all that. And so there's need that as we keep our feet on the pedal, on this particular advocacy, we are also mindful of this other effect that might come with it. And down there, that's the team that of the civil society organizations that we worked with on this particular work. Next, Erica. And we have some planned, future planned activities. The Hunger Project Malawi continues to sit on the Family Planning Subcommittee, and so we'll continue to drive this agenda of domestic condom financing. And we have now engaged in interacting with the district teams using the Hunger Project evidence, so that we now work on financing not only at the central level, but also procurement of these products at within the district budgets. And down there we have the 3 potential advocacy action points, which we have not embarked on them yet, because this was also again a one-off support that we had received. But we look forward to getting resources that we could continue with the work of making sure that our members of parliament could conduct a learning visit to one of these areas in the region, and then to be able also to start working with to target the multinationals and the private sector, so that the diversification, the shift from donor-dependent condom financing does not only end up in the hands of the government, but also with the private sector, which is well known for its efficiencies. And lastly, next slide, Erica, would like to acknowledge the support that we received from the International Planned Parenthood Federation. And thank you all for your attention.
Thank you very much, Rowlands, and for sharing the work that you've been doing to build the case for male and female procurement budgets. So we're going to pass over to our final presentation from Moses. Over to you, Moses.
Thank you, Erica, and thanks for the opportunity to present. My presentation is about budget advocacy in Uganda. From 2005, advocates ensure that the Ministry of Health establishes an account that is specific for procurement of contraceptives and selected RH commodities. And we're glad that that account was set up and ring-fenced. And since that time, as advocates, we've been tracking budget allocations and expenditures and reporting to stakeholders on a regular basis. And that forms the background to what we put in this grant to ensure that we further this budget allocation and expenditure in terms of its outlook. Next slide, please. Yeah, so the goal of this project was to add the RH supplies resource tracking module onto the Uganda Ministry of Health RMNCH online web-based resource tracking tool by 2015. And below there you can see that's the website that the ministry developed for tracking reproductive, maternal, newborn, child, and adolescent health resources. It's www.ugrmnchtracker.org. Next slide, please. The background to this is that in October 2014, Samasha was contracted to really develop a resource tracking tool in response to the Commission on Information and Accountability that requires countries to report on expenditure per capita by source on RMNCH resources. And good enough, Samasha was already involved in budget advocacy for FP, and we felt that we could position ourselves to ensure that now we create a special module for tracking FP commodities budget. Next slide, please. What is the innovation in here? The innovation is that we've been collecting data every 3 months, tracking the budget allocations. But the innovation with the new system is that it's a real-time online tool. So every time there's an expenditure and allocation is posted on the website by an individual organization, and it is seen in real time. And there's no need for massive number of data collectors to start running around looking for data. And the beauty of this RMNCH resource tracking tool is that each individual organization actually has its own account. In other words, confidentiality of individual organizations' data is kept intact. However, the visuals and reports are accessible anywhere. If you're in a meeting in New York, a meeting in Japan, a meeting in Mexico, you're able to just log on and see what's happening by a click of a button. Next slide, please. So the way we implemented this is we wanted to ensure that the reproductive health commodities budget is onto the RMNCH resource tracking tool, but not only on it, but also to be one of the visuals on the home page. So we developed a policy brief, and we had to target the key decision makers within the ministry, and those key decision makers were Tom Aliti, Commissioner Planning, Professor Muwonge, Director Health Services, the late Dr. Colin Singwire, Commissioner Reproductive Health, Maurice Seru works with Pharmacy Division, and Ed Mukoyi works with the Health Management Information System. These were the key decision makers that could help us move our agenda to include budget tracking onto the RMNCH module. And after we had discussed with them and given us a go-ahead, we developed terms of reference for an IT expert to develop the module. And we had an IT expert, and he worked on the module. After its development, we uploaded and tested the module, and then it was reviewed by the ministry, and later on, after it was updated, later on we updated the module on the website. Next, Erica. What were the lessons learned? Lesson one is that any advocacy project must be well thought through and very clear. Here we had a very clear objective. We knew whom to target, and we knew the technical experts in terms of IT development. Lesson number two is that you should not hire an IT expert alone. You should hire an organization. Because in the middle of implementation, the person who are using left, but because you are working with an organization, they replaced that person at no cost. But that person had the institutional memory. The last one is you must have and build good relations with the Ministry of Health people to be able to advance any advocacy agenda. Next slide, please. The results of the project, it has helped elevate the profile of reproductive health, family planning commodities, because now everyone says, wow, you've been doing a good job from 2005. We can see the graph, and I'll show you the graph later. But also institutionalization of this good work is really something that we are proud of as advocates within Uganda. The last slide, next slide. I've been talking about budget advocacy, and this is the graph that we've been working on as advocates to ensure that resources are allocated and resources are expended. If you can see on the graph from 2005 to 2009, allocations were being made. However, there was no expenditure. But with concerted effort and support from advanced family planning for partners in population and development, we've been able to really do strong advocacy, and you can see resources have been allocated and expended, and this needed to be visible, and the best way to have it visible was through the online resource tracking tool. Last, Erica. Yeah, we would like to acknowledge the Ministry of Health, IPPF, Reproductive Health Supplies Coalition, and partners that helped us to be able to achieve this innovative achievement. Thank you so much. Back to you, Erica.
Thank you very much, Moses, for that presentation on the work you did to institutionalize a real-time online resource tracking tool. So we have about 25 minutes left, and I'm going to turn over to questions and comments from participants. I just remind you that you can type your question or your comment in the chat box at the very bottom, and we will take questions and turn them over to our presenters.
Hi Erka, this is Emily. We don't have any questions yet at the moment. I just wanted to mention that people can also raise their hand. You have a small yellow hand. If you raise it, I can unmute you and you can ask your question yourself. We just got one question from Susanna Dennis from PAI. A question for Rowlands. She wants to thank you for your presentation and congratulate you on your success. Did you coordinate your advocacy with HPP and the other Malawian CSOs like GCM, FPAM, etc., who were responsible for getting Malawi's family planning budgets funded? So Roland, maybe you can take this one.
Thank you. Yes, I can confirm for Family Planning Association of Malawi. We coordinated with them. We also presented this work before implementation and even after implementation on the platform that we sit in, on the family planning subcommittee that we sit on, coordinated by the RHU. So, and with a number of NGOs, civil society organizations that we managed, plus Manaso, Malawi Interfaith AIDS Association. So the list, the logos that I presented there was not exhaustive. So we worked, interacted with quite a number of NGOs that we worked with in Malawi.
Thank you. And then we have Habib Salami from Pathfinder who has a question. So I'll just... Hi, Habib.
Hi, Hope. I'm actually based in Pathfinder Nigeria office. We are implementing the AFP advocacy work in Nigeria, and I'm very interested in the work that was presented by AFP Indonesia, particularly the work at the village level where the family planning village team was set up and the achievements they've been able to make. I just wanted to find out what the structure of the health system is like at the local government and the village level in Indonesia, if it's similar to what we have in Nigeria, and we'll really be interested in trying to implement similar activities here in Nigeria. We currently support advocacy working groups at the state level in Nigeria, and through that supporting advocacy at both state and local government level. But I think this provides an opportunity to go deeper down to the local government and the community level. So if they can share more information on what they did at that level, I think it will be helpful for us back in Nigeria.
Thank you, Habib. Dini, that's a question for you.
Okay, thank you, Habib. How are you? Fine, I guess. For the village actually the village leaders, the village government is report the village government report to the district government. So even though the village has the authority to develop their own agenda and also budgets, they still need to develop an inline agenda with the district agenda. So that's why at the district level we have our district working group working with the district stakeholders, with the health office and also the family planning office to facilitate to facilitate and support the family planning village team in developing their work plans and also strategies. And then in between the district and also the village level, we have sub-district government. The sub-district government mostly only supervise in terms of budget disbursement, but the program and also the development goals is help facilitated by the district government.
Thank you, Dini.
I hope it clarifies. Yeah.
Now we have a question from John Skibiak for Moses. The slides show the dramatic decline in the level of funding for commodity procurement in Uganda. So John is asking why that's declining and if Samasha has used those figures to advocate.
Thank you. I thought someone would miss that, but John, thank you. The issue of the decline is, maybe I would call it due to the system, because what we did in Uganda is that we decided to use the funds for procurement of two commodities. One is maternal health kits, and the other one is for contraceptive Depo-Provera. What has happened is that the government procured Depo-Provera, and there is an overstock of Depo-Provera at both national level and health facility level. Though there is a stock out of other commodities. But for the government side, they felt that since they were supposed to be procuring Depo-Provera and Depo-Provera is available, they were not going to procure any more Depo-Provera. So they reallocated the funds to procurement of other RH commodities. That's one reason. The second reason is that Uganda has been implementing the health system strengthening project, which is supported by the World Bank, and within the procurement plan of that project, they were procuring commodities, including contraceptives. And because the project is a World Bank loan and the government of Uganda will pay back the money, it was considered that the expenditures on that project were part of government resources. But unfortunately, the project is coming to an end. All the procurements that were supposed to be done ended. So this financial year, there was no procurement from that project. So if you look at the previous budget, money was allocated and spent. This year, the money has reduced because we've removed one of the source of funds, which is the World Bank Health System Strengthening Project. However, the third reason is that we've always done budget tracking starting at the beginning of a financial year. This financial year 2015-2016, we started budget tracking in March of 2016. So we lost roughly 7-8 months to track financing and help reallocate resources to where there was going to be a stock out. So those are the three reasons I would like to say that affected budget allocations and expenditure. However, we hope that in the next financial year, which has just begun, we shall commence budget tracking as early as possible.
Thank you, Moses. We have a question from Justas. Hi, Justas.
Hi, this is Justas. I was inquiring on the process the first president used in formulating the village working groups. Did you formulate your own groups, or you directly worked with the existing groups? Because we have challenges with the existing groups where we find the issues capacity building. Others are uneducated and others are very old, but they are the existing village health workers. So we find a challenge in selecting them towards working with them. So I wanted to know the criteria the first presenter used in forming those working groups, because the end result is increasing access to reproductive health services, which is at the bottom of the advocacy, leading to allocation, budgetary allocation to the reproductive health products at the district level, which later is translated into the development plan and later to the national level. However, all is grounded from the village level. Which criteria did you use to select the working group? Thank you.
Dini, it's a question for you.
Okay. In the initial phase of project implementation, before we developed, we established the district working group. We first met with the district head to have his blessings and support for the implementation of the program. And then the second one, we advocate the district family planning office, and with them we assess the networks existed in the district level. So we encourage the district family planning office to involve family planning duty bearers and also champions who already work alongside with them. And then after that, some of the district they have already existing team, and some of others they have to form a new one. And for the existing team, actually at first we have the same problems with you, so that's why we have we advocate the district head to endorse the team by issuing a decree for the working group establishment. And because of the decree and also the endorsement from the district, the team have like a responsibility to be part of this district working group.
Thank you, Dini. And then we have a question from Erica to all three of the presenters. So in your three presentations, you all mentioned how important it is to collaborate, civil society collaborations, but also working in partnerships with the government. Can you explain a little bit more how that's been a success in your project? So maybe we can start with Rowlands, and then we can have the other speakers respond to this question.
Thank you. In the first place, working together with other CSOs really proved very useful, because besides the fact that we removed the picture of appearing as if it is a one NGO agenda, so that it becomes an agenda for a wider group. So it helps to remove that lone voice syndrome in advocacy. On the other side, it also helped us to benefit a lot from the strength that other partners, institutions that have. I can give an example, a specific example when we're developing the policy brief. When we did the draft and we came together, we really benefited quite a lot from specialists in development of policy briefs from other institutions who inputted quite critically into the policy brief, and it came out much more stronger than it would have come out if it was only the Hunger Project developing that policy brief. And further to that, working with the government, in partnership with the government, in this particular case, actually, we had to, because the way we're targeting the government, it's not against the government, but it was in partnership to say, here is the gap, and already it is actually the government which is already complaining or facing the pain of declining donor support. And so it was easier also for the government to understand the case that we made to them. So we found that these particular approaches, bringing in other players at the same time, engage with the government not from the antagonism point of view, but as a partner, as we are all committed to ensuring that we provide this particular service in an effective manner to our people. So we found that quite a successful approach in the implementation of this advocacy work.
Thank you. Moses, for Samasha's project, why was it so successful to work together with civil society and the government and other actors in Uganda?
Yeah, our project, we did not really engage so many actors because we had a specific target. Because there was this online tool and we wanted the Ministry of Health to include a module. So we had a specific target, and that target were the 5 officers of the ministry. The only part that we included civil society organizations was the dissemination, for them to know that actually they can access information on a website rather than going to offices. But it's important to have a strong partnership with government, but specifically the decision makers. If the decision makers understand why you're doing something, it becomes very easy for them to make a decision to work with you to achieve your goal. So to me, anything we do, if we don't partner with the government, and if government doesn't appreciate that you're working to help them, then your project will have difficulty in achieving its outcomes. Thank you.
Thank you, Moses. Dini, do you have anything to add from Indonesia's perspective?
Yes, because we're in IFP Indonesia, we engage so many actors from multi-sector and also at each level of government. And we have learned that each actor has their own role in filling the gaps in the implementation of family planning in Indonesia. And then also, if we only engage the government, the rotation of local government officials and politicians are highly frequent. Therefore, it is very critical to involve other institutions such as midwife association and academician and also others. I think that's what we have learned by engaging so many actors.
Thank you, Dini. And then we have one more question from Susanna Dennis. Hi, Susanna.
Hi, this is Susanna. Rowlands, you can tell I'm really interested in advocacy in Malawi. And I'm just curious, my understanding is that there isn't a separate space for CSOs who are working on advocacy and reproductive health to come together, that all of the coalitions or groups in Malawi are convened by government or have government as part of these coalitions, like the Family Planning Technical Working Group, etc. So I'm curious if you see a benefit in having a separate space for organizations doing advocacy around reproductive health to come together.
Yes, come in again with your question, sorry.
Is there a dedicated space for civil society organizations doing budget advocacy in Malawi to work together, or is there a need?
Okay, yes, I think there is a need for that. We have the Mehin Malawi Health Equity Network, but there is a need for that space, and as you know, there is a positive civil society space in Malawi currently. And so the platform I spoke about, the family planning seat that we sit on, is actually convened by the government, the RHD department. But even though it's convened by the RHD, you can actually influence the processes on that particular platform. Even when coming up with the agenda for that particular platform, you contribute in different civil society organizations involved in family planning and all that, contribute towards that particular agenda, towards that particular platform. But to have a separate platform for civil society on advocacy, on health or family planning and all that, which is not convened by the government, yes, there is that need. And I wouldn't see any problem in coming up with such a platform in Malawi for now, because until now there continues to be a positive space for civil society operation in the country.
Thank you, Roland. Moses, another question for you from Justus. Are you planning to use technology in the stockouts in district and the national stores?
I think there's some noise, Erika. Emily, we are getting out of noise. I don't know from where. I can't hear what you're saying.
So there is
Hello?
a question. Do you hear me?
Yes, I can hear you now, yes.
There is a question from Justus for you, and he wants to know whether you're planning to use technology more, and when you want to address stockouts in district stores and national stores in Uganda.
To be honest, already there's technology being used to monitor stockouts. We have initiatives like the Stop Stockout initiative being funded by the Reproductive Supplies Coalition, implemented by HEP's project, and we have also the PMA 2020. They gather data using mobile technology on stockouts, on family planning commodities. I think it was been every 6 months. Now it's going to be every year. Within the Ministry of Health, there's a project called the SURE project. They are really tracking stockouts in terms of using technology and the LMIS systems that have been set up in pilot districts. So there is a lot of effort to see how we can use technology to track stockouts, but none of those has been scaled up to cover all the health facilities. But it is something that is being piloted. However, this tool is, and also we have what we call HMIS, the DHIS, the ED, the electronic district health information management system. They track stockouts of Depo-Provera. However, as Samasha, we've basically concentrated on budget advocacy because we feel the space for tracking stockouts is adequate. And so in summary, we've not really, and we are not planning to venture into tracking stockouts. But we are so much interested in ensuring that resources available to prevent stockouts.
Thank you, Moses. That was our last question. So, Erica, the floor is yours again to close this webinar.
Thank you very much, and I want to thank all of the participants who asked great questions and for joining us today, and thank you also to our 3 presenters. Thank you very much. Have a good day.
Thank you, Erica. Thank you so much, Erica and Emily. Thank you.
Thank you, everyone.
Bye-bye.
Bye.
Bye.